Come to the pictures.
Welcome to Kind of Science in Trondheim. Good evening. Thank you for taking part in this edition of Kind of Science. And I want to say will host you through the evening and the different and interesting aspects of the pandemic, while Arpanic will be responsible of the technical management of the hybrid event.
Yes, so tonight the focus will be on the different aspects of the COVID pandemic. But before we start, just some general comments. First of all, just a reminder to keep your masks on when you're walking around.
batches that we produced, they are very reproducible, so they have the same response
and maybe speak.
Oh, my pleasure.
We checked the reservations and we were the first ones.
Yeah.
Of course. They advertise the whole thing through my flash.
You brought us, or like, yeah, you brought us.
Yeah.
Yeah.
I have to show my support.
That's still very nice.
It's too bad that, it can't be bigger
Yeah.
with a little bit of wiggling around. And things
Yeah,
like
yeah,
that.
definitely.
But it was muted.
We're
Muted all of them, but
one. Said it's only 10 people. He's got in quarantine, so he's not here.
Very important. Well, I brought my friends, Prague and Adrian. But it's all right. Yeah, all 3
because
days.
yesterday worked. So did we?
All 3 days.
Is it because we have one more laptop
Like
now?
tag team with people.
You're a bit of a right.
Cool. And what are the topics tomorrow?
Tomorrow it is about it's about more small stuff.
Okay, cool.
And then on Friday it's about space.
Yeah, I'm looking forward to the space. It's pretty cool. Well, okay, sure we can keep it, but we already ordered everything.
Yeah, everything works.
As a bulletin.
Check the. I don't know when you said something. But yeah, I guess we can get back to it. Come on, so now you can see the stream. You can see. Just need
Proceed with our next speaker. So he's already coming up.
You've given my
Oh.
away.
Oh, there it is.
Perfect.
No.
No?
There.
This one. So our second speaker, Indra de Souza, he's a professor at the Department for Sociology and Political Sciences, and his expertise lies in a completely different field than what we've just heard. So he is an expert in the field of international relations and something called political economy, which I've only just learned what that means. He might be able to elaborate a bit more about that himself. And he knows a lot about causes of wars and peace and about governance. And it's going to be really interesting to hear his view on this pandemic and how democracies and specific political systems deal with this crisis in different ways and why we're seeing specific trends in specific countries based on the political system. So yeah, can we just give him a warm welcome?
I have a big mouth, so I could just speak without it. Or do you have to have? Oh, this one. So I'm a bit daunted. It's daunting following Sulalit, which is a very concrete issue that solves a real problem and has real science behind it. But I'm a social scientist, so it's probably not real science, and it's probably not solving any real problems. So, okay.
That's right.
Thank you very much to the organizers for inviting me. It's a real pleasure and an honor to be here. I'm going to talk about this research that we have done. The concept of democracy is a broad, big thing, but most of you might recognize it as something that policymakers, global and local, average citizens, and even political scientists, a large bulk of us, would think of as being like, aspirin to a doctor, right? So a doctor might tell you for any problem, take an aspirin and call me in the morning. And for policymakers around the world, or even political scientists, the solution to any problem might be take a democracy and call us in the morning, right? So that seems to be the answer. So how does it work when we think about democracy and actually responding to problems? So the question of democracy is always a question about governance, right? So when we think about democracy, we think of representativeness. It's a good thing. Why shouldn't I be able to choose my own government, right? It's about rights. And of course, when we talk about governance, we have to always think about effectiveness. Because what's the point in talking about governance if it's not really doing anything for you, right? We might as well not have a government and have rights and all those other good things without government. So obviously, we think that something about representative governance is also about effectiveness, or delivering something that we in society as individuals or groups or whatever actually want, that governance actually fulfills an interest. The folk theory of democracy, which is what everybody thinks of democracy, which is why it's like aspirin to a doctor, is that it's representative, and because it's representative, it's responsive, right? Because after all, I am being represented by my representative, who is then responding to what I want, right? Which is why he's going to govern for me. And therefore, since it's representative and responsive, it must be also effective, right? Because he's presumably going to deliver what is it that I want, my interests. So, but is this how democracy works? By and large, most of it might work like that in very fortunate cases. But in general, a more realist theory of democracy might be to say that the world is a lot messier. We are constantly angry at our representatives, right? Nobody hates anybody more than a politician, maybe lawyers, but hopefully there aren't any in India. But we don't even like our politicians, right? In fact, we trust them the least when you have these global polls about, who is it that you trust in society, right? We trust our pets more than we do politicians. So the problem is that you can't just aggregate interests. It's impossible to aggregate everyone's interests because we have different preferences. We have different interests, and just having an election is a very simple way of trying to aggregate interests, but this doesn't mean to say there aren't people that are pissed off after an election simply because their interests are not met. And so compromises is what politics or democratic governance is about. It's not about some pure representation, but it's about compromising interests. And compromises, as you know, is often not satisfactory to everyone. After all, it's a compromise. So democracy can be slow, but under most circumstances, because democratic processes take time, I have to find out what people's interests are before I try to respond to it and so on. And therefore, they can be slow. Compromises are hard to make, and compromises may take time. And of course, making policy slowly might not be a bad thing. It's like home cooking in a way, and it might be, at the end of the day, more effective. And that's how most people say democracy might, at the end of the day, given all its faults and all the problems, might in fact be better because you can stumble along and change your mind if you have to. But we also know that democracies have other sides to it. Assuming that our governors, our policymakers are in fact responding to our interests is not a given, because democracies can have some of these other characters who might mislead, right? Because we assume that people know what their interests are, and they assume that their interests can be satisfied in some satisfactory way, that we would even know that our interests have been satisfied. And if you are typically dealing with populist politicians, then they don't even have to pretend to have to represent you, because they simply know that they have a voting bloc around some kind of issue that's going to get them re-elected, right? A nationalistic card or some kind of religious ideology or something that can keep them elected. So in many ways, democracy needs a lot of ingredients to bake it well. And in order to bake it well, you want smart citizens, people who are able to identify what their interests are and whether those interests are in fact reasonable, and good politicians who are going to deliver on their promises of solving and being responsive to those interests, and of course strong institutions that are in place to punish politicians who might otherwise be tempted to misrepresent what they have been elected to do. Okay, so it's not as simple as simply thinking, let's take a democracy and call the doctor in the morning. It might be a lot messier than that. So enter the COVID shock, right? Here's a good sort of natural experiment to see, how do political systems respond to these kinds of shocks. So we as political scientists have generally thought about democracies as being different, and the best-baked democracies are somehow the ones that have the smart citizens, the trustworthy politicians, and the strong institutions. And one of the ways in which you can think about that issue is to think about high trust, high educated, high well-functioning institutions as being the kind of egalitarian, the more Scandinavian type democracy, which, we can sort of discuss these things afterwards. But the argument is that in these democracies that are in citizenries that are fairly equal, where you have governments that are responding to social needs that are in fact pro-poor, and the rich and poor have very small differences between them, you have sort of greater transparency, greater accountability, less polarized interests. In other words, we live apparently in Scandinavia in the kinds of societies that are the better baked democracies. So of course you face this problem of what then is this idea of social trust. Political scientists or social scientists talk about social capital, that where social capital is high, the kinds of public problems and shocks that societies face are dissipated better and are better handled under these conditions. And that's kind of the way in which the Swedish experiment rested, right? In other words, you have a high trust society, you trust institutions, you trust the experts to do the policy making, and these kinds of democracies are more flexible. They can, in fact, navigate difficult waters a lot better. And so were the Swedes right? We don't know. It might be too early to tell. And that's the caveat, which is that COVID is a sort of a fast-moving target, and perhaps our analysis for the moment may have jumped too far ahead, but we have responded to some early studies that have tried to show that democracies have been worse at handling the COVID crisis, but our input to this debate, so to speak, was to say, hey, not all democracy is the same. You've got to try to look at these more egalitarian types of democracies relative to other types of democracies. And then we use two waves of the COVID crisis that we had, and we had deaths. And these death data are basically generated almost every day by Oxford University, the COVID people there, a group that formed around addressing public policy for the COVID crisis, and they worked in tandem with the WHO and national governments around the world. And so we use these two waves of COVID deaths, and what we find is that, in fact, egalitarian democracies don't do very well. So this argument that these kinds of well-baked democracies are better does not hold water. But that is independently of whether or not you have good access to good healthcare. And it seems around the world that the egalitarian democracies don't necessarily have the better kinds of healthcare systems. So you can take a country like Singapore to compare with, or Taiwan, or even Rwanda, in a very poor country setting in Africa, has done very, very well simply because they have healthcare systems that have a high reach and treat capacity for whatever reason.
Is there any connection to clean water?
Might, but this research has not looked at that specifically. But we do have things like wealth in our models, which should capture, how wealthy you are, because that's connected to the
No, because I'm from the States and the water sucks.
Okay.
Here the water is quite good.
Not just the water, but we'll talk about those things. Yeah, so what are the findings? The findings seem to suggest that dealing with shocks requires some kind of hierarchical structures rather than simply the more democratic horizontal structures. And these hierarchical structures, obviously, we would prefer the ones that are more enlightened, which means that public policy is dictated and made by experts. For example, this sounds a bit elitist, but it's from a social scientist, so it's nothing that I would believe on a regular basis, but that means shocks require particular kinds of policy responses that may have to be outside the context of what we think of as being representative responsive governance, if indeed what we want is effectiveness. Of course, nobody would say you throw the baby out with the bathwater, right? Democracy has all these other good things that come with it that we value as democratic publics, but at least our research tells us you've got to think hard about how we reform democracies for responding to the next crisis. In many ways, poor country democracies face COVID crises every year. Trade shocks, currency shocks, financial crises, social shocks from the point of view of bad political movements, terrorism. All of these are shocks to poor country systems. We only have felt this because we felt the shock because it's a pandemic, right? So how we think about democracy and governance should be far more nuanced than simply saying, take a democracy and call me in the morning. And so while we think about how we reform democracy for dealing with the next health crisis, might mean that we put in place both systems that safeguard democracy into the future, but also systems that help us deal effectively with shocks without having this kind of democratic burden of slow policy making and response. After all, governance is about being effective, Otherwise, we can just live without it. Thank you.
Sorry. Thank you so much, Indra. This was, again, a very interesting talk from a completely different perspective. And yeah, you touched upon a lot of points that I at least hadn't considered. I'm just wondering, so you think that this pandemic might cause our democratic systems or our political systems or governance to sort of shift? Do you think that will be a global pattern, or do you think that it will go back to normal, or do you think this might have some drastic implications for the way policy in general in the world approaches?
The really optimistic, perhaps even the realist view of this is that where our institutions are strong, it's not going to have that much of an impact. That yes, democracies will be slow. People have died, unfortunately, many of them and large quantities of them in the democracies. And that is a testament to the types of things I touched on: slow policy making, perhaps even lack of trust in sort of elite top-down approaches, and so on. So we've seen the marchers against sort of lockdown measures and all these kinds of things. So perfectly willing to give up their rights for more surveillance, give up their democratic principles for putting people in prison without due process and so on. The Guantanamo Bay type things, even in a strong democracy like the United States. So hopefully that kind of anti-terror thing will not be used by governments in the future to say anti-COVID, let's go the other way. I don't think that's going to happen, but people are using it. So in places where democracy is weak or is not there, like Belarus and other places, they're cracking down on people who are pro-democratic in the name of COVID or lockdown in order to try to get control for themselves. But I don't think this will happen in countries where democracy is already strong.
Thank you so much. Any questions? Question in the back? Yes.
Following what the statement you made about, let's say, democratic countries, perhaps put these rules for the future. Say, if there's another virus comes, you just take democracy from people. But if there is a less polarized interest, such a country like Scandinavia or Norway, how do you want to make sure that the democracy is met and actually reflects on all population, not only individuals who actually, let's say, they have their parents, they have their family, but not working immigrants, not second generation of immigrants, actually that, yes, they are citizens, they are residents, but they still have part of their life or family somewhere else.
And specifically, you mean like travel restrictions that might impede?
Yeah, also that visiting a family is not an emergency travel, unless it's for the funeral of the family. And this is very inhuman, the statement, I believe. And when you talked about when a country has less polarized interests, that means there is no group or political group that actually challenge the government or the people who are actually in power to challenge them about these movements they make in understanding state.
Yes, if I understand you correctly, the view that more egalitarian, high trust societies, the better baked democracies, will be able to navigate these issues a lot better than more polarized democracies or even autocracies where it's all top down, right? So that was the expectation. In fact, the Swedish expectation was, yes, let's listen to the experts, but at the same time, the economic costs are going to be so high and there are so many unknowns. Let's take this other approach, which is some kind of belief in the idea that people would automatically listen to their governments and have social distancing voluntarily and so on, and therefore you get herd immunity by these natural processes, less drastic processes. Yeah. Whereas in Rwanda, you can simply say, nobody's traveling anywhere. We are having, complete lockdown, stay at home, blah, blah, right? So, yeah. But of course, now we know, at least in the kind of the empirical expert literature, that democracies were worse at that than the autocracies, simply because autocrats can implement policy for whatever reason. They may not care about people dying, but for whatever reason, their political futures or whatever. Yeah.
I have actually one question. In your research, did you find that the different kinds of democracies, as we divided, like representative democracy and monetary democracy or direct democracy, did this have any effect on a very theoretical or from a social science perspective?
Yeah, so what we were responding to a spate of studies that had looked at just democracy versus autocracy. Typically, a democracy is counted as one that has a country with fair, regular elections where people aren't coerced, that there's political competition and so on. Because democracy is such a wide term, how to understand it. So our entry into this debate, at least me and some of my public health colleagues, was to say, well, not all democracy is the same, purely for the reason, the question you asked, and simply say, well, let's look at what high trust democracies, or let's see if there's anything to the Swedish expectation about how good democracies will handle this. But unfortunately, what we wanted to find is not what we found. That what we found is it doesn't matter whether you look at something as democratic, black or white, you're more egalitarian versus non-egalitarian. It seems that the autocrats have managed better. And that means that something like lockdown and drastic measures are required for fighting something like a virus. Right? And that means stopping travel, blah, blah, blah. And so one of the questions we asked is, well, aren't we assuming too much about so we are assuming that all countries, democracies and autocracies, are exposed to viruses the same way, right? Because the travel regimes might not be the same, the trade regimes might not be the same, but we were able to account for those things by looking at things like tourist arrivals, pre-COVID, as well as trade dependence. So how much do you trade with the outside world? So we were able to say that despite being exposed to the virus and travel and other things, democracy didn't do as well. It's a disappointing finding, but at the same time, one that we need to be realistic about, because fighting crises might require other things than simply say, take a democracy and call it a movement.
Do you also think that related to this egalitarian versus non-egalitarian democracy, is there something that has got to do with paranoia in egalitarian society more than implementing policies?
I don't know what you mean by paranoia, but you mean something like, shouldn't an egalitarian democracy be more worried about their democracy being taken away? Yeah, that's right. So that was kind of in the back of our minds. That is, that the Swedes are responding to the danger of too much lockdown, whereas Norwegians, I don't know, for whatever historic reason, is simply saying, okay, let's go along with the government. Norway is actually one of the countries with the highest trust in political authorities, right? For good or bad, we don't know. So that's it touches on a much larger debate in the social science about this idea of what is social trust, right? What is social consensus, and so on. Right? we don't want everybody goose stepping. That's not a good idea either. Sometimes minority opinion is far better check on majoritarian power. North Korea, everybody is agreed that, their leader is good, but that's not what we want, right? Democracy is about the contest of ideas, and the contest of ideas require that space in which that contest of ideas can take place.
Thank you so much. Yes, another question.
So I think I've got your point that autocracies are able to handle it better than democracies just because they can implement policies faster. But isn't an element in this that the numbers that autocracies report may not be entirely correct? There has been a tendency to that in the past.
Very good point. So in other words, are the numbers tainted systematically by autocratic underreporting? Very good point. The Oxford people and the WHO that collect this data, and some others who sort of double check and triple check these things, are very, very careful about how they report these numbers. So we want to use the first and second wave, which means that most of the death numbers have been now verified. So my research colleagues are collecting the third wave data as well, so that we can bolster our studies into the future. And it will be interesting to see how many of these are actually revised upwards or whatever. But in general, by looking at deaths, those are things you can't really hide that much, because the WHO has some very clear guidelines, which are then checked by local authorities in every regional hospital, even in the most remote areas around the world, where the death, was it due to some underlying condition or was it due to the COVID virus? So suppose there was a heart patient that died, they had to verify that that was because of the COVID virus and not just because of the heart patient.
Excellent. Well, I think we have to wrap up just in terms of time for this part of the session. But before we take a 10-minute break, I think I'd like to give our lovely sponsor Dion the opportunity to share a few words with us. Indra, thank you again so much for coming.
So I'll just give a very brief introduction about DION. So it's the interest organization for the PhDs and postdoc and other scientific temporary employees at NTNU. So we have 8 people in our board, democratically elected every year during annual general meeting, and we have a president also. Martin is our president for this year. So DION is a very low threshold contact point for all the PhDs and postdocs at NTNU. So anybody can contact us and ask for queries. We also try to organize events for the temporary employees, and we try to sponsor events like we are doing this time for the Pint of Science Festival. And we interact with other organizations also at NTNU. We interact with the National Doctoral Organization, SIN, S-I-N. And we have contact with the other labor unions like Tekna or Forskarforbundet. So we try to talk about the rights of PhDs and postdocs and temporary employees at NTNU. We collaborate with the NTNU student government also, and our main focus is the social integration of the international employees working at NTNU. So we try to organize different kind of events. Last year it was a bit difficult for us for the COVID, but still we try to organize different online events So we had a cook along with Dion, where Musab, our previous board member, taught us how to make butter chicken. So it was quite fun. And also, we try to give grants for organizing different kind of events. So anybody who is working at NTNU as temporary scientific employee, they can apply for grants. And every year we send out different kind of grants, at least up to 6 grants per year. So soon we will be announcing the call for the grants. And anyone can join the Dion board. Anyone working as PhD or postdoc at NTNU, every year we'll have our annual general meeting in April. So people can vote, and then you can join Dion board. I would ask everybody to follow us on social media to stay updated, and you can subscribe to our newsletter also. You can go to our website, ntnu.no/Dion, and subscribe to our newsletter. So thank you.
Thank you so much, and thanks again for supporting our event. This is really great. Like, we wouldn't have been able to make it possible without you guys. So I suggest we take another 10-minute break, and then we'll be back for a third speaker who will be joining us online. So still very exciting, but yeah, you'll be looking at it on the screen. So yeah, I'll see you in 10 minutes.
All right.
Such chaos in here. Hi, can you hear me there?
Yes, I can hear you.
Oh, we can't hear you
I,
yet. Can you please speak up?
yeah, so you can't hear me?
I think you unmuted.
Yeah, okay.
Yeah, I have no sound yet.
Yeah,
No. Let me try something else then. Yeah, he's unmuted.
But here it says unmute.
No, that's this computer, because there's 3. I'm talking from this one. So it's a bit confusing.
you can't still hear me.
Yeah, we might need to Yeah, no, HDMI is not actually. Okay, I'm going to try to change the PC,
Okay.
and we'll see if I can hear you there. Yeah, I can see the presentation, so I think it should be fine. If you then click for
you hear me too?
slideshow, I think it should be
Can you hear me?
good on the streaming.
Can you hear me?
No, I can still hear you. We're changing now the equipment a bit, so hopefully I can hear you in a moment.
All my notes and everything.
Can you try to say something now, Terja?
Can you hear me now?
Yeah.
Yes? You can hear me? You can't. Yes, I'm talking. Can you hear me now? Still difficult? Oh, that's great. Super. By the way, do you know how to share my screen in a way in which I can see you and my presentation at the same time? It's not a big deal, but it's a bit boring only to watch my presentation. But it would be good to see the audience as well.
Can you hear us now?
Yes, with a bit of an echo, but I can hear you well. Yeah. I just want to know if you know how I can share my screen in a way in which allows me to see you at the same time. That's fine. Because now it's not in presenting mode, right? It's you see all the slides down there, I guess. Yeah. Because now I guess you see my full screen, but I can't see you. That's the. Okay, so I'll start my presentation when you tell me to. So then I'll put it in presenters mode. But until then, it's good to see the audience as well, which I do now. Okay, you just tell me when to start, and we will expect you to talk for 20 minutes, 15 to 20. That was the last thing I heard.
Hey, can you hear us now?
I can hear you well. Can you hear me?
Hi. Yeah, can you hear us now?
Yes,
Yeah,
super.
you
Yeah,
can
great.
go now.
So you want me to start?
Yeah, you can start now.
Super, super. Hello everyone. On my screen I can't really see you, but that's fine. I would expect that you're enjoying a few beers, a pint or a few, along also with Indra, the last presenter. Take one from me, Indra. Sorry I can't be there with you now, but I guess that this is just part of the everyday life and also working life nowadays, that we have to use Zoom and other equipment. My presentation today will also deal with COVID, and it will moreover show why it's so important that we keep an interdisciplinary perspective on the situation we're in. And my name is Terje Andreas Eikemo. I'm a professor of sociology, and I've been researching topics like global health, inequality, chronic diseases from both a social science and a medical perspective. So in my presentation today, I will start with presenting the research center that I'm directing, presenting some of our key research before I go on to the topic of today, which is the double burden of COVID-19. And you might already wonder what a double burden really refers to. Of course, I will jump to that in a few minutes. But this is just also a warning that I'm aware that you have a quiz afterwards. So I will mention a few names, maybe places, years. So you have to pay attention. I've given my questions to the organizers. This is Chain. And Chain is a research center that I'm leading from Dragvoll here at NTNU. And we're really proud that we have a global research center on inequalities. This is a center which brings together academia, the public health field, public health experts, the UN system, civil society organizations to examine the causes and the extent of health inequalities in the world. And we also try to present solutions to reduce the global health gap. We started in 2017, by merging a local research group here at NTNU with UNICEF Norway. And since then, we have grown and expanded, and we're now bringing together researchers from many regions and disciplines to really advance the health inequalities research area. Our aims are threefold. We are interested in we are monitoring health inequalities in the world. We are basically observing how health disparities their trends over time and through space. And we're also interested in explaining why we still see a health gap between and within countries. But we're also attempting to reduce these inequalities by identifying interventions that work, by suggesting policies that can reduce the unfair inequalities in health that we see in the world today. And moreover, we have a global perspective. I think that this graph or this figure might summarize a lot of it. We are looking at socioeconomic position as a determinant more broadly. For example, education, but also income, occupational conditions, living environments, social policies, and so on. And we are trying to see how that relates to various kinds of health outcomes, including various forms of mortality, cause-specific mortality as well. And as you can see here, it seems to be a perfect correlation between the level of education in the world and mortality in the world. But in fact, it has been very difficult to provide solid proof that there is actually a causal effect of education and other forms of socioeconomic standards on health. But before I go on with the rest of my presentation, I want to briefly give you a heads up on a very important publication, which is just around the corner. It will be published in the Lancet in a few weeks, and very strategically up front of the G7 meeting, which will happen in London in the beginning of June. We have been able to provide the most comprehensive evidence to date showing the degree to which lower education of mothers and fathers is a risk factor for mortality in children under the age of 5 all over the world. And this is a collaboration with the Global Burden of Disease Study, which you might have heard of. And we are showing that the educational attainment of mothers and fathers is important. Actually, the importance of fathers' education has been under-communicated in the past. We are also able to show that each additional year of education counts. So it is not only about securing universal primary education. So the more education, the larger the chances for child survival. And education matters everywhere. Maybe the most striking finding is that there are no patterns showing that education is more important for child survival in Africa than in Scandinavia. We also have child mortality in the global north, but the degree to which we have that is to the same extent explained by parental and education all over the world. So how does all of this relate to COVID? Well, it's about fundamental resources, such as education, but also income, living conditions. It's about working conditions, it's about healthcare access, and all of these fundamental resources, and they relate to health, but also to COVID. And we are now more or less stepping into the topic of today. It is very easy to think that COVID-19 is really affecting all of us equally, because COVID-19 is not discriminating. It is, it doesn't stop at the borders. COVID-19 does not have to show a passport. It really hits all of us. So it's easy to think that it is maybe an equalizer, but of course it is the opposite. We are not all in it together. It might sound a bit contradictory, but my presentation today is about why we are not all in it together, because emerging evidence suggests that COVID-19 is experienced unequally, with higher rates of infection and mortality among the most disadvantaged communities, societies, and countries. It is not a socially neutral disease. And in order to understand this, we need to learn a term. This might be a new word for some of you, a syndemic. We are not experiencing a pandemic. We are experiencing a syndemic pandemic. And this means that there are several pandemics that work together at the same time. And the term syndemic occurred a few years ago, defined by Meryl Singer. And she used the term to understand the relationship between the AIDS epidemic and the substance abuse epidemic and a violence epidemic in the US in the 1990s. So these were different epidemics that worked together and kind of reinforced everything and made it stronger. So a syndemic occurs when risk factors for illness are intertwined, cumulative, and interactive, and thereby increasing the disease burden and its negative effects. So another question, of course, would be, okay, we have one pandemic, we have the COVID, but what is the other pandemic? It's this one. It's a pandemic of chronic diseases. And chronic diseases, such as diabetes and more or less all of the non-communicable diseases that you can think of, they are also socially structured. So COVID-19 is a syndemic pandemic because it interacts with existing inequalities in chronic diseases. And it also interacts with the social determinants of health, which you can see here. The kind of virus lookalike that you can see here in the figure really refers to the fact that that food and education, housing, healthcare, unemployment, access to services, these are important determinants of health. But they also interact with COVID. So people with lower education are more often hit by the virus. So people with poor housing are more often hit more severely by the virus because of overcrowding and so on. And this relates to all of these factors in this figure. So the prevalence and severity of the COVID-19 is magnified because of pre-existing epidemic of chronic disease. And this is also what we saw in 1918 with the Spanish flu, which was also experienced unequally. So there's a lot we can learn from the past, because historically pandemics have been experienced unequally with higher rates of infection and mortality among the most disadvantaged communities. So emerging evidence from a variety of countries suggests that these inequalities are being mirrored today in the COVID-19 pandemic. So who is COVID-19 likely to affect more? Well, minority groups, people living in poorer areas, people living in poverty or working in low-income jobs, marginalized groups such as homeless people, prisoners, and street-based sex workers. And why is this? Well, for two reasons. Because these groups are the same groups that are also more likely to present to have underlying risk factors, such as diabetes, as I mentioned, but also hypertension, asthma, heart disease, liver disease, cancer, cardiovascular disease, obesity, and so on. And these groups are the same groups that are more likely also to face adverse working conditions, unemployment, less access to goods, and so on. So these are, this is why COVID-19 is likely to affect these people more. So basically, underlying chronic conditions and unequal living and working conditions can increase the prevalence and severity of COVID-19 infections. So in terms of working conditions, why are people with poor working conditions more exposed to the virus? Well, that's because they work in lower paid jobs that are more and they're therefore more likely to be exposed to unsafe working conditions, which in turn will increase the risk of certain cancers, hypertension, stress, and anxiety. And they're also required to go to work. They don't have flexible works like me, for example. I can have the speech from home or from my office. And people with in terms of living conditions, well, lower socioeconomic groups more often live in poor quality and affordable insecure housing. Overcrowding is a serious issue, and also lack of outdoor space, and increased risk factors for chronic conditions, such as stem conditions leading to related illnesses. So these are examples of why underlying chronic conditions and unequal living and working conditions can increase potentially the prevalence and severity of COVID infections. Of course, we are still in the pandemic, so we still need to check the data in a few years if this really is the case. But based on the experience from previous pandemics, it is very likely that this is the case also now. And we do have some evidence already which can confirm this. For example, the rate of COVID-19 infection is 3 times higher in the most deprived areas of Catalonia in Spain compared to the least deprived areas. And evidence from the US have shown that that there is a dramatically increased risk of death observed among observed among the most disadvantaged areas in the US. And the COVID-19 mortality is twice as high in the most deprived neighborhoods in England and Wales. And here are some further numbers. So the Black, Asian, and minority ethnic people in England and Wales, they amount to 14% of the total population. But in fact, 34% of this group became critically ill. So among all people who became critically ill. So there is an overrepresentation among Black, Asian, and minority ethnic people. And in the US, the COVID-19 mortality rate for Black Americans was 114.3 per 100,000 population, compared to only 61.7 among white Americans. So, and if we would assume then that they had died at the same rate as white Americans, we would have saved 21,000 Black American lives. So definitely, we already have evidence that the pandemic is experienced unequally. People are dying at an equal pace among different social groups. And of course, it doesn't really help that we are experiencing a vaccine nationalism, which really points to the fact that the high-income countries are securing their own populations through various kinds of agreements with vaccine producers. So we now see that 33% of high-income countries have. So these are the doses per 100 population, which is currently at 33 in high income, 10 in upper middle income countries, and only 5 in lower middle income, and almost nothing in low income countries. So why does this happen? Why do we see such unequal distributions of vaccinations in the world? Well, this is a figure which can explain it. So the line that you can, so the dynamic line that you can see, the thicker line, points at how new technologies, including health technologies and the vaccine, would be absorbed in the population. So in the beginning, it would be the early adopters, like the richer countries, they will get the vaccine first, and then the laggards would be the last one to get the vaccine. And this happens because there are some fundamental resources that the richer countries have, such as money and power, that enables them to secure their own populations. And it will only be in the last phase, when all countries have the vaccine, that we would see also that the vaccination rate would reduce inequalities. But by definition, when there is a new innovation coming, it will increase inequalities rather than reduce them, even though we are trying very hard to secure an equal distribution of the vaccine, at least within many countries. So the first, let's say the first burden is the fact that relates to the fact that people are affected unequally by the virus itself. But these are the same people who will be most affected by lockdowns, by the consequences of the virus. So the impact of the Great Lockdown and the economic recession on health inequalities is something that should be taken into account as well, including the policy responses, such as lockdowns, but also other policies. So not only are the poor affected by the virus itself, they're also affected most by the consequences, the political consequences that we have to implement. So this can happen because of housing conditions, in terms of overcrowding, little access to outdoor green space. Lockdowns are experienced unequally also because of working conditions. Job loss and income loss affect the poorer more, and also in terms of physical health, reduced access to healthcare services for non-COVID-19 reasons, which will affect the poorer more, and also the strain on mental health and gender-based violence will affect poor areas more. So these were some examples on that. And moreover, the longer term and largest consequences of health inequalities, they derive from political and economic pathways. And we know this from previous sudden economic shocks. So when like the 2008 economic crisis, which really led to increased unemployment, this had really serious consequences on mental health and mortality in Europe. So we can expect that the health consequences of COVID-19 will be similar to the economic crisis that we have experienced in the past. But again, we need to wait a few years to see if this is really what is going to happen. So what can be done? This is my last or second last slide with a few suggestions. It is important that when policies are implemented, we have to weigh the gains against the consequences of introducing measures. But what we do know is that it's really important to invest in social protection services. We need to invest in public services when times are bad. because countries such as the UK, Greece, Italy, and Spain, who imposed the so-called austerity, so they implemented significant cuts in health and social protection budgets after the financial crisis, and these countries experienced worse population health as compared to countries such as Germany, Iceland, and Sweden, who opted to maintain public spending and social safety nets. So we need to basically reduce inequalities, and we need to reduce inequalities in access to essential resources. We have to make sure that the COVID-19 itself and the consequences are not increasing existing inequalities. So yes, these were my words. I know that the audience is a quite clever one. I listened to some of the questions that Indra got, and you seem to have been preparing well. So I look forward to some questions. Just a small warning that I did not really catch all the questions that Indra got. So perhaps the questions need to be repeated by those who are holding the microphone, or at least keep the questions short and clear and might hear them. So, but thank you for your attention. Please do follow us on our various social media channels. And yeah, I hope to meet you next time.
Try now.
Can you hear us? Okay, we can't hear you.
Okay.
Now you can hear me, right?
Oh, no, you can. Can you still hear us?
There's a huge echo.
Thank you so much for a super interesting talk.
Let's see now.
Now it's good. Yes, perfect. Yeah.
But we don't hear you then.
Okay.
I don't hear the echo anymore. It's good to go.
Yeah. But no Telia either.
Is it possible
I can hear you.
to turn the noise back on when he's talking?
Yeah, I think we're gonna do that.
Yeah. We'll just talk.
Yeah. We do our best. Yeah, there will be some reorganizing for tomorrow. Yeah, but then the way we're gonna do this, we're gonna ask the questions, and then I'm gonna switch the sound, and you will be on the speakers, and then I'll switch it back for more questions. So let's go with the questions first.
First of all, thanks for a very interesting talk. I had a question. When you said a syndemic pandemic, I was really trying to think really hard. Is there any pandemic that is not syndemic? I'm just trying to think of a disease that would not affect people unequally.
It's a great question. So it is possible to distinguish diseases according to their level of avoidability or preventability. So you can think that some diseases are impossible to, or some causes of death are impossible to avoid. And for these causes, we don't see that they are more frequent among lower social groups, let's say. So, but preventable conditions, so conditions that you can really prevent by, let's say, changing your behavior, or if the healthcare system would work perfectly, or if you're able to avoid, let's say, accidents or harming yourself. For those preventable conditions, we always see a social pattern. So you're right. For these conditions, there will always be a pandemic. So if another pandemic is coming along, it will always interact with the existing pandemic, which we see and which we have now in terms of the chronic diseases. But the interesting thing is that we have not always had the current let's say, pandemic of chronic conditions. 100 years ago, 200 years ago, there were other diseases that were not related to our lifestyles, like diabetes was not socially distributed in the way it is today. So it's also about time. Time seems to change disease patterns, and time changes the way that that diseases are really hitting us. But there will always be conditions that are active, that are kind of hitting us unequally at all times. But the type of diseases will change. The type of, let's say, mortality will change. But there will always be some conditions we can avoid, and for the avoidable conditions, we will always experience a pandemic. So that's true. The question is, of course, what other pandemics are active at the same time. Now it's COVID, and in a few years it might be something else. So it was a very good question.
Yeah, is it long enough? Can you try the other one? I think it's longer. You can turn it on.
All right, that's cool. So thanks for the lecture, Terje. My question is, you know, for ages and ages and ages of human history, a lot of, you know, health and living standards have been really connected to access to clean water. Simple as that. Clean, potable water. And if you want to study health inequalities, that seems to me like something that would be very quantifiable, because you could take samples of water, look for bacterial contents, look for lead contents. You could get repeatable results through many different labs and things like that. And that would be something that would be very good to work off of. Whereas education and things like that, I mean, you can count up degree certificates, but those degrees are in many different things. And as I like to tell my students, a degree just means that you can do a set of tasks within a certain time frame. It has no idea how, it has no indication of actually how educated you are. So do you do anything like that, something that you can actually quantify and something that can be repeated and get the same results through many different labs or different people who study it?
Can you hear me now? Again, fantastic question. And I would say that more generally, we look at the topic on public health topic as an empirical topic, not as a discipline-related topic. So, and that is why my answer to your question is that we also do that. We are interested in the smallest building stones, like to the genetic setup, to our brain, to global forces, to trade. So we're looking at everything, both in terms of determinants, but also in terms of outcomes. And that also includes lead, for example. So, and that's something we have been doing. And we just recently published a study showing that mothers that lived in more deprived areas have had higher proportions, or how to say proportions, concentration of lead in their how to say the milk, right? So in the breastfeeding than others. So that was quite an astonishing finding. We have also been around the world collecting samples of sand in refugee camps. I will not say where, because this is a very sensitive issue, and I'm not sure if I'm even allowed to bring this up. But more generally, I can tell you that we are collecting samples in areas among vulnerable settings, and we're bringing them back and testing them, and we find like disturbing results. But we are not sure how to share these results because of ethical issues. I'm not sure if it's even allowed to bring such samples through customs, but we have now been, we're trying to do everything right now so that we can present such results. So we are doing that too. We are an actionable group. We are not only doing, let's say, research and associations. Education is particularly important for us, and that is not because we think that there is a direct effect necessarily of, let's say, if you send someone an educational diploma that he or she had all of a sudden receives a PhD, it would not affect your health much, right? So it's not about what is on the paper, but education is a fantastic proxy on so many other things, and it relates to like health literacy. It relates to also access to water. It correlates. It depends where you live. And all of this relates to some fundamental resources that are always important. And we could think of, there are 5 like fundamental resources that would always shape our health, regardless of time and space. And that is knowledge. It's like non-material resources. You have income. You have social networks. And you have the power and prestige. So these 5 have been identified as the fundamental causes of inequality that interacts with conditions. I do think that education is quantifiable, and I'm not trying to misunderstand you. The problem is when we start to explain why education is important. But education is also so easy to measure. So, and it's stable over time. People change their income, they change their occupation, but education is stable over time. And the problem is always to find the links and the mechanisms. And the mechanisms linking education to health, they vary according to region. In Norway, it's something different than in Central Europe, Eastern Europe, or in other parts of the world. But really establishing the fact that there is an association between, let's say, mother and father's education and child mortality, and that there's a linear relationship, which we have just discovered, is, I think, as a first step, really bringing education up as a global determinant of health where it belongs. I think we need to look at the different sciences at the same time, both social sciences and the natural and technological sciences, and we cannot ignore each other. And that is also why we like to work with, let's say, the artificial intelligence lab. We are, for example, mapping schools in the world. We are using satellites to find schools, and also to, in areas where we are not aware of, in the Amazons, in Brazil, for example. We're trying to see if they have internet access within these schools, to see if that can be used as a measure of wealth within these schools, to see if it also relates to child mortality in the regions. So we're trying everything we can really to see how the distribution of resources is also correlated to the distribution of severity of disease. So that's how we work. But I agree with, I will never disagree with anyone who's trying to look at specific mechanisms linking that to health. It's an empirical question. It's not a discipline question.
Thank you. Anyone else have that?
Yeah, try now.
Hello. Hi. My question is related to the decision of the order of giving the vaccine. As you were mentioning, in some areas, the COVID was being contagious much faster, like in some areas in Spain that were really populated, for example. And it seems like everyone has agreed in different countries to start giving the vaccine, starting from the elderly, and then it goes down from all the eldest. And I was just wondering, would have been maybe better to focus on these areas where they are so highly populated that any spread can have very dramatic consequences, and that people need to take the underground to travel to work. And yeah, I was wondering if you have thought about that.
Yeah, so the distribution of the vaccine is it's a sensitive issue, and I don't think it has any doesn't have any correct answers. I think that more than looking at the within country distribution of the vaccines, I think we need to focus increasingly on the between country distribution of the vaccines. I think that's where the problem is. The problem is that I will probably be invited in a few weeks to get my vaccine. That's the I think we need to look at the global skewness on the distribution of the vaccine. I think it's needed. The access of the vaccine is highest in the areas where it's needed the least, if we look globally. But of course, if we take into account and assume that the vaccine is reaching populations at the same pace, then we could start thinking about also the within country distribution. And but there are so many things to think of. Of course, we could start with the according to age. You could start according to occupation, or at the same time. You could start according to regions, according to or where the disease pressure is the largest. I think that countries are really thinking carefully through, finding their own strategies, and it's difficult to sometimes argue whether it should be done differently, because I think that the logic is the same everywhere, that you really want to make it as efficient as possible, but at the same time, should you start with health workers, with teachers, with the elderly, with those who have underlying conditions, with those who are in living in the most dense areas. So there are so many priorities, and it's difficult to see whether you did the correct thing until you really tried it. But I'm more concerned with the global skewness than the within country skewness.
There's a question in the back, and there's a question from
I got another one.
Did you have one as well, right? No, you're fine. Okay.
Yeah, Terje, it's me again. Hi. One thing that just it's always amused me in some kind of strange way is prior to the COVID. For instance, in Trondheim we have the Miljøpakke, which has been encouraging us to take public transportation, and to go out and walk to work or take the bike, and expose ourselves to the elements and things like that. And to me, it seemed like that they were setting us up for the pandemic, to make it worse. Have they thought to reassess these kind of things? Because, it seems like the safest place is my car. It's private and it's clean. I keep it clean at my own standard and things like this. So, there's some contradictory things with the public policy. And has this been discussed or talked about in any way? And for instance, they want to introduce the open office around the department, which, a lot of people just kind of went, really? In the COVID times, an open office, does that make any sense? So, there's been prior to the COVID, there's been so much for us to just use and share all the same kind of things, for us to all get together and sort of be mobbed and packed in all these places. And all of a sudden the COVID comes, and it's it's putting a stake in the heart of the Miljøpakke. It's putting a stake in the heart of all these other initiatives that they've taken, like the open offices and things like that. Have these kind of studies of society and the impact of COVID and anything taken into account these kind of contradictory sort of goals that they have now?
Yeah, it's yeah. Well, indirectly, there are some studies on that, but they can't really show or demonstrate any effect yet. I think that your question is more, let's say, it's a very interesting question and observation. But to your first comment, of course, is this all staged? I don't think it's staged, but it sounds, even in all of this, all of the darkness, let's say, it's a bit interesting to observe naturally. But I'm more concerned with the dichotomy between the medical field and the social and economic field. And I'm not sure how this relates to your question, because I'm kind of going a bit away from the original question because it was too detailed to answer. But I'll reflect on it a bit broader. So all decisions that are being made by epidemiologists all over the world from the medical field. It's a medically dominating field. About lockdowns, about should we send our kids to school or not? When should we wear masks? It's a very instrumental medically oriented advices that we're getting, and I think it's around 9 out of 10 of decision makers are based in the medical field. And I'm slowly coming into the field that you just mentioned, and the more social field, about how we live and how we experience company with others, if it's in an open space area or if it's just hanging out with friends. I think that it's important that when such important decisions are made that are affecting our lives, these decisions should be made by perhaps a larger group of experts that represent a larger sections of society, representing more occupational groups, including teachers, including directors who are making these suggestions and sitting in open space or in closed offices. It should include philosophers, maybe. It should include university professors like myself or others. It should include childcare workers or social workers. So I think that perhaps the decision would be exactly the same. But I do think that it would be wise to have a broader set of decision makers in the discussion of the decisions that have been made, because decisions are basically affecting all of our societies. Of course, as long as we are making decisions based on solely epidemiological reasons, then we do everything we can to secure that we are not affecting each other. I think we should do that. That's not my point. My point is that we should also think about the consequences for children, for social interaction, for mental health. I strongly believe that the consequences of the COVID crisis will far exceed the consequences of the virus itself. But of course, this is impossible to prove at the current stage. And this does not mean that we should relax, that we should take easy on things. But it means that we should think deeper and more long-term whenever decisions are being made that have such major impacts on our lives. So that was not a direct answer to your question, but at least it made me think further about how the medical field should perhaps communicate more with other sectors in our society.
I actually have one.
Do you need the microphone?
Yeah, do you guys hear me?
Yes.
Yeah. Yeah, I actually have a question. Yes, so I have a few facts and then a question following. So I'm hearing in the news that Great Britain has bought 3 times the amount of vaccine they need, so they could vaccinate their population 3 times around. And then I'm hearing in the same time that India, which is one of the biggest vaccine producers, is struggling to vaccinate their own population, and not only for the cultural reasons. That has been the issue before, but now it seems like everybody agrees that they need to get vaccinated, or at least the vast majority. So I know you're an expert in health, global health, I could say. And so I wonder if you could just let your imagination go wild. How can we fix such big inequity? How can we aim towards, what kind of moves should we have to do as global citizens or as people of the world, not specific nations, in order to get rid of those economic, medical inequities that we see now? The richest or the most vaccine producing countries struggling to survive COVID-19, and also vaccinating rates being so diverse there.
To some extent, your comment does not really need any further thought, because it stands alone very solidly. I think that every country in the world has a right to protect their own populations, and they do that. And it seems that they are, and then we are. We're not seeing this as a major problem. I haven't seen any major discussions in Norwegian media problematizing the fact that the Norwegians are being that we are getting the vaccine on the expense of other countries. I think the discussions nationally in Norway are focusing on the fact that those aged up till like age 30, like between 20 and 30, those are the laggards. And I think that's what we read in the media. That when is it my turn? When is it my turn? That's a discourse. That's what we see every day. And at the same time, we read about all the deaths in India, and that's terrible. And that's also in the news, but no one seems to put those together, right? So you don't have discussions on, well, should we wait? Should the Norwegian population and other populations with very strongly built welfare states, where we can perhaps afford to wait a little longer on and letting other populations get our parts first. I think we should start with ourselves, and it's very difficult to get into such a discussion without thinking about ourselves. Because once we go into this discussion, the Norwegian term, meeting ourselves in the door, right? So that's one place to start. With ourselves. But then this is also a political issue. It's a global political issue. It's something that the World Health Organization has been working on, also together with the UNICEF. So they are establishing a program which is very promising, which is securing more vaccine doses to global populations. So something is definitely happening at the international level. But that is not because of countries like Norway. That is perhaps despite of. I think the question should go back to each and every one of us, and that you should not expect me to tell you why this is wrong. But I can, of course, point at some mechanisms on why this is happening. But unless something happens from the deep of the populations, which nation dares to go first? I have not seen this yet, and I really miss this in the Norwegian media, but also elsewhere, including in the UK. And they're even securing many more doses than they need, naturally, and they're even securing the contracts with the producers before before the companies are able to produce them. So they secure them themselves before they know actually if they will be delivered. So and this is vaccine nationalism, of course, for good reason.
Yeah, can you hear me now? Yeah, I think it's really remarkable how politics can really affect global health, and at this point, it's almost unethical to think about that we have, or to some extent, we as citizens, we have some say into how this plays out. But then again, as we heard also from the presentations before, it looks like the autocratic systems work better, where you actually have like a guidance from above, and you have to follow up. And if you don't follow up, then well, there's consequences. So it's very, very, I think it's very remarkable, and it's also very contradicting in a way from a person just living in through those times. But in the same time, I was thinking about COVAX initiative and all those European initiatives where we try to share some percentage of our vaccines in order to distribute them in poorer countries. But then I'm also hearing in the news that there's a number of poorer countries that just give back certain types of vaccines based on a rumor or on non-scientific data. And that's even more shocking to me at this point, because we're realizing that there are so many nations struggling really day by day going by, and it's not only the economy that's being struck, it's really many families being affected. We don't feel it so much here in Norway, since there are not so many cases here, but I hear in the news more and more, and then I hear same country would be giving back so and so many millions of AstraZeneca vaccines to COVAX because they can't use it because people don't show up for vaccination. Now, how do we deal with that part of it? Of course, I know you would say again, we have to look back on ourselves and reflect on how we act, but there are really strong cultural differences and that also contribute to those inequities. How can we fix that in a way, or how can we aim towards a solution there?
I think my answer this time goes along the same lines. I think we have to make sure that we are not over-ordering, that we are not putting ourselves in a situation that we have too many vaccines, that we take into account as well that not all of us will accept the vaccine. And perhaps we are not even able to distribute the vaccines in a speed which allows us to use all the doses within a certain amount of time. But over calculations are being made to secure populations, and it goes in the same manner. But of course, we should enable mechanisms to make sure that the doses that are let's say leftovers, that they are being brought back in a systematic way, in a well-planned way. But we take into consideration that this might happen even in Norway. And the COVAX initiative is, I think that's the global savior, it seems, at this time. But what I'm asking us to do is exactly what you guys are doing now. So, and having a debate on this, and that's the first stage. But at the same time, I think that when we are offered a vaccine, that we should accept it. This is not our fault as citizens. We can of course make a political statement, but when we are offered the vaccine to ourselves and our families, we should accept it. But that does not free us from the responsibility we have to raise the quite difficult issues that are associated with it on a national level. towards our politicians. But perhaps that's part of the reason why we don't really see so much complaints. It's much easier to demonstrate against, let's say, the war, which is going on now in Palestine, because we are not directly affected by it. So it's much easier to stand up. While there is another war which is going on over the whole world, but we are not stepping up to the same degree, because we are perhaps a bit partial in that. So, of course, I'm now just speculating and discussing this issue. It's not something where I can put hard evidence behind. The only thing I know is that that inequality matters. It's so COVID has changed the game, but inequality is still a key player in the distribution of population health.
Perfect. I think we're going to have to start wrapping it up a bit because we're already over time. But thank you, Terja. I'm not sure if you can see us clap. And I'm glad that we started this debate. And I think it's, for me, you've touched on some really interesting points that I hadn't considered myself. So thank you so much for this. I think it's a really nice wrap up of the evening. But before you guys leave, it's time for the Kahoot. So we hope you all have paid attention very well. But before we start, we need the actual app. So it's called Kahoot, K-A-H-O-O-T. Arctic will set it up. So we'll get a code on the screen. And basically what you need to do is type in that code in the Kahoot app, and then you'll see that, I hear some Kahoot sounds already, so then you'll see the questions on the screen. And basically, it's not just a matter of answering correctly, but also speed matters. So, yeah, we've got a number of questions for each speaker. So,
Yeah, let me just set it up.
I think, how many questions have we got in total?
12.
Is it a team effort or individual?
Individual.
Individual.
Oh, sorry, boys. You're on your own.
Oh, there he is. Nice. Did I set it up here? Yes.
22.
It will appear on the yeah.
Who will play?
This one. This one.
Not just use a plug-in. Right for the game.
What's the game then?
Coming. Game pin's coming.
Yeah, coming up. Actually, just a moment. Just
Let us know if we need to wait for you to set up your Kahoot app.
There.
We must have been able to, we must have had to do the lectures ahead of time from the speakers. in order to make the quiz.
Yes.
That's very difficult.
Some of the money can be behind.
Exactly. I would totally do the same if I had a lecture.
We have some for Thursday that we're still waiting.
That's
There
it,
we are.
175, 133.
Yeah.
170, 51, 33. Pin. If you could use a name that you actually remember is you, would be great in terms of handing out the prize.
There's a prize.
Really? Whatever the winner is? She ain't right. It's very simple. She said,
Yeah, no inappropriate names. played this with children too many times. Dan Glee balls.
I just use my initials. Very, very, very clean and family friendly.
You don't see it though. Let me see. Like this. There we are. Yeah. There we are. Are we still waiting for more people?
COVID, okay. 1, 2, 3, 4, 5, 6, 7, 8, 12 people. 13. Oh, we've got a lot of players. It's good. There's 250 kroner voucher. Is anyone not in who wants to be in? We're still waiting? No? Ready to go?
All right.
Okay, let's do this.
I can't read the yellow.
Less than a year.
Less than a year.
Well, all of them are correct. You know, less than. Sure.
Yeah.
Hey, Trey, man. All right.
It's a number.
Yeah.
It's a number.
I thought it was a dance.
A digit. No, I mean like a digit. Sorry, I mean like a digit or typed. It doesn't matter.
11. There we go.
Oh, nice. Lolo in the lead, followed by Shampoo and H.
Wait. Skip too fast. There you go.
Is the COVID test currently being produced at NTU?
Yeah.
Shampoo's on fire with 2,605, followed by Lolo Joseph Perep.
Oh, I'm in last place.
Yes, democracy has done worse than totalitarian countries fighting against COVID deaths. Gonzalo moving up.
Can't read the yellow.
Only the totalitarian countries.
Okay, can you turn up the sound from the...
I can't. That's the sound issue we have.
Okay.
Yeah. It's bit of messed up audio.
Ooh, Lolo in the lead.
Oh, there's Bag. Singer.
Back climbing up. Whoa, bag of
You
more.
better watch it, Gonzalo.
5 questions left. What is chain?
I know, I'm totally handicapped. I can't say that before. But I'm feeling competitive.
Only 2 got this right. With the Central Health Center. Mar moving up, bag moving down.
Oh, Gonzalo.
Neck to neck. Where's the next G7 meeting taking place?
Shit, I was out smoking. Singapore. Detroit, man. We can hope.
Paris. UK, England, United Kingdom.
Oh. Getting some feedback.
Does this count toward points?
Yeah. Apparently. I skipped too fast. Too late. You're gonna leave the I didn't.
Please be honest. That will only help us improve for next year when there's more people.
Yeah.
And when it's not hybrid, hopefully. Well, we'll still be hybrid, hopefully. It's anonymous, so it's fine.
Yeah, I mean, one of the depressed guys.
Probably the beer's nice.
The beer's warm.
The beer is warm.
It's alcohol-free beer. He's a designated driver. He just got dumped. His pal didn't show up.
That's great.
His pal didn't show up to have beers with him. No free food, sound problems. Couldn't hear the audience questions. Good point.
Yeah.
Time slots weren't maintained strictly. I apologize. Nothing specific. The weather, technical difficulties. Thanks, guys, for your feedback. I really appreciate it. What other feedback? Anything else you want to share? Do it now for be silent. No, that's not true.
The quiz was too hard.
You have 2 more days to practice.
All right. It's going to be the same answers each day.
Well, now you know that.
And that I had to like remember numbers and things. That was
Can take notes.
all right. I'll show up with my notepad and my glasses. My book bag.
Okay, so the podium on third place, Gonzalo. Woo! Lolo, second place. First place is drum roll. Shampoo. Shampoo.
Who's Lolo? Who's Lolo?
Who is Lolo? Hey, that's win first.
Yeah, that's cheating, man.
Okay, Shampoo, we've got your gift card here for you. And then, is there anything else that?
Wrapping up the video. The dog.
Ah, that's how Lolo got out to the lead.
Stop it.
First three.
Or should we play it on Friday? Okay, can everyone see the dog?
So, yeah. Yes, so we're doing it again next year. Anyway, we'd like to thank you all so much for physically attending. We really hope that you don't get a COVID notification within the next few days. But yeah, no, it was we're really happy that you were here. I think it was also nice for the speakers to have people in the audience. We hope you enjoyed your beer and the Bali Shared Habitat. And for those of you who are coming on the other days as well, we look forward to seeing you. And yeah, please tell your friends if they're keen